Hey, Dr. Rosen, how are you?
Hey, friend of the show, fellow Virgo.
Yes. Hey,
Another Virgo?
We're
Wow, I am outnumbered.
Hey, look,
I'm a Scorpio.
hey,
Virgo,
fellow
I'm always like really
Virgo.
good friends with Virgos, though.
we're totally unpredictable.
Completely.
Dr.
That was Gemini.
Rosen, Janine, Beyonce, you're in good company. Awesome. Well, hey, so we have lots to talk about today in your nice warm seat, because I'm not going to like throw anything crazy at you. Yeah.
I'm ready for it. I've had a patient day today. Today was a non-operative day.
Nice.
I've been talking to patients about GLP1s. I've been talking to them about how, they don't have to say things like, I know I could be trying harder, because it's so ingrained in them that just giving their normal effort is like substandard, because it's beaten into them. They have to give this superhuman effort all the time.
Yes.
Yeah.
It's so true.
I've been rolling all day.
Yeah, great. So this will just be a
Yes.
nice transition. I like it.
Oh,
So
I like that.
we know
Yeah.
lots about you, but our audience may not. So can you tell us a little bit about you, what you do, what you're about?
Sure. My name is Daniel Rosen. I've been a weight loss surgeon and doctor for 15 years now, and I'm board certified surgeon practicing in New York City. Surgically, my practice is split 50-50 between bariatric surgery and complex hernia surgery. It's all done minimally invasive, which means with cameras, laparoscopically, or robotically. I don't do any like big cuts, put my hands in there and move stuff around. It's all like tiny little instruments where I'm like controlling stuff. And then my medical practice is mostly, involved with GLP-1 weight loss medication, which has just blown up in the last, 18 months or less.
Yeah.
So
Well, that's awesome. Would love to know, I like how GLP-1s in general, like how do they really work, and how are they like or unlike, bariatric surgery? And there's of course a few, so you can explain that to us. That would be great.
Besides the obvious, Besides
sure.
Thanks, Kat.
Yeah.
There you
Well, GLP-1s are amazing.
Yeah.
And they're a paradigm shift, game-changing medication. Whatever superlatives you want to throw out on there are, for the most part, appropriate. And the way they work is really innovative. GLP-1 is a hormone that your body makes. It's made at the end of your intestines. And you have to think of your GI tract as constantly sending information to your brain. It might be sending something like, I'm really distended and I'm filled with air. And that may show up as like a cramping sensation, right? But the cramping sensation is created in your brain based on signaling coming from your intestines, okay? And then your brain is making you aware of that because it's sort of unusual and painful. But it's always sending information to your brain constantly. Is the stomach empty? Is the stomach stretched? As the nutrients move down the intestine, those parts of the intestines where the nutrients show up are sending signals. Hey, there's food here. Hey, there's no food here. Send more food down. That may manifest as hunger. So you're constantly getting signals from your GI tract, both neural through what's called your vagus nerve and hormonal, where the cells release hormones into your bloodstream, which circulate to your brain. And the end of your intestines have a special cells that produce GLP-1. And the GLP-1 hormone, when it reaches your brain, makes you feel very full. Okay? High GLP-1s would be associated with that feeling at the end of Thanksgiving dinner, when you're like, you have to push yourself away from the table, when you're like feeling the food in here.
Yeah.
Okay? But
he's pointing at his neck, listening audience.
There's no food in your
Right.
neck. There's no food in your chest. The esophagus isn't filled up with food. But what's happened is food has reached the end of the intestines. And the intestines don't want you to lose nutrients. And they can only process things at a certain capacity. So when you've overwhelmed the system, meaning food is making it to the very end and still isn't fully processed, that those sensors can pick up that you have fats and proteins that haven't been broken down and absorbed yet, and they will be at risk of being pushed into the colon and lost forever, which for your body's perspective, evolutionarily would be a disaster, because when will the next meal come?
Yeah.
Is the famine around the corner?
Mm.
You know, the body evolutionarily has no idea that there are bodegas on every corner and liquid drinks filled with calories. Like in nature, there was just
Yeah.
water. That was so you can't even pick out the calorie content of a liquid, because for a million years it was always zero. So the body didn't evolve to pick up how much calories is in a liquid. So the GLP, you know, the notion of losing nutrients into the colon is a disaster, and the body will do anything to stop the input once food has reached the end. So GLP-1 creates this tremendous satiety signal or a fullness signal in your brain. So these GLP-1 medications, when you inject it, it stimulates the release of that hormone from that part of the intestine, even though there's no food there.
Yeah.
So you're tricked, your brain is tricked into thinking you just ate a huge meal, even though you haven't eaten anything.
Yeah.
And
That's
that
awesome.
that makes you full,
Yeah.
even though you haven't eaten. You're not even like not hungry. You're like, I'm not interested in food. I'm not thinking about food. On the day after your injection, it might be 5 o'clock before you even realize that you haven't eaten anything, because you don't have any hunger signaling or triggering. And you also may have, you know, some studies are starting to show, and certainly reports from patients who are on the medications, all of those added benefits. After you eat a full meal, you may not worry about what's going on. You just may feel satisfied and good.
Yeah.
You know? And that can be the decrease in food chatter that people talk about, the decrease in anxiety, a calmness that they experience on this medication. All of those sort of ancillary benefits that people are reporting, typically because of GLP-1. Now let's talk about weight loss surgery. Okay. Talk about a band. A band is a mechanical roadblock. Okay. It's a device that's wrapped around the very top portion of the stomach and creates a holdup of food. And as the food goes up in the esophagus, it creates discomfort, and you stop eating because you don't want to vomit. It's sort of a negative feedback inhibition.
Yes.
You know, behavioral modification to not eat so much because you don't want to vomit and you don't want to feel the pain of having the food build up above the band. It really works mechanically. And one of the main reasons it fails so often is how counterproductive it is hormonally, right? And Kim, you will probably be able to speak on this, but I'm sure there were times where you ate a certain amount, you were very hungry, you ate a certain amount, you filled up that space right above the band. You knew you couldn't eat more.
Yes.
Mechanically, but you weren't satisfied.
No.
That deep hunger was still there.
Yes. Yes. That is 100% what it was like. Yeah.
Wow.
And then I think eventually my stomach, the non-banded part, kind of started getting smaller and smaller because I was eating less and less. But there's also a way to kind of defeat the band, which is you drink when you eat.
Right.
Right. And a lot of people do that because I found I wasn't getting enough water. I was constantly dehydrated. So, I mean, like I would drink when I would eat just to try to get it in. And
Just
that
to
would push
sort
the
of
food
lubricate the system. That's
Yes.
one of the things with weight loss surgery patients we tell them not to do.
Yeah.
Because we don't want them to lubricate the system. We want the food to build up. We want them to feel full. And you're asking like the body to not satisfy itself. And if there's a way for it to get those nutrients that it wants, it's going to do whatever it can. It's going to convince you to drink when you eat. It's going to push you to ice cream, you know, or cheese, which is very soft, you know, that
Cereal.
will go down the band. You know, cereal and milk, which is almost like cake when it gets soft. You know, if you think about a sugar cereal with milk. And the hormonal effect of a band, think about it. Is food really ever getting to the end of that intestine? You're eating less mechanically, but it's going to be absorbed at the same rate because your intestines haven't really been changed.
Yeah.
And your stomach makes ghrelin, which is a hunger hormone that we don't often talk about because there isn't yet any medication that suppresses it to help with weight loss. But when the band's in place and you lose weight, it's just like losing weight with a restrictive diet. Your ghrelin goes up, and so you're hungrier. So your hormones are working to defeat the band in most cases.
Yeah.
A gastric bypass or a sleeve have significantly different hormonal impacts than a band. And I'm sure that this wasn't all spelled out for you.
No, I was
You had this,
27.
and that's
They may have spelled it out, but I wasn't listening because I was 27. And I was like, oh, really? I'm
you
getting
were
this
like,
and insurance is paying for it. It's going to make me lose 100 pounds. Awesome. You know, like, you know how you
but were
are.
you thinking band all the way in, or were you led by your doctor?
I mean, I basically went in and just, I mean, I think banned. I had seen an episode of Oprah where there was a girl that was very young, like who had gotten lap band, and she was talking about it. And I thought, oh my God, like maybe that would help me. Oh my God. Like, because I've been binge eating since I was 8, you know?
Right.
So I went in going like, I don't want to have gastric bypass. And keep in mind, there was no like sleeve or anything like that in 2007, you know? So I went in and I was like, this is what I want to do. And my insurance will pay for it. And like, you know, and they were like, yeah, like it's 1,000 times safer. Let's do it. And I was like, oh, cause I was really young. I didn't want to,
Right.
you know, put myself, and I also wanted to have a child, and I was concerned of what that would be like, you know, and the band was very much like positioned to me as it can be removed. It can be removed. Like
Right.
I can't give you your stomach back if I take it away, but like I can, you know, and that's how they would say it. It
But
was very
nobody, and that's all like standard lingo by a doctor who wants you to get a band, you know, especially a doctor who only does bands.
yeah.
You know, I do bands, sleeves, bypasses, revisions. So
Yeah.
I can offer whatever's appropriate for the patient. I'm not pushing them specifically to a one procedure that I do.
Yeah.
And the reversibility argument doesn't really hold because you have a chronic disease.
Yeah.
And you don't want an intervention for a chronic disease that's reversible. You want something that's reproducible, effective, with a low complication profile. No one says like, I have stomach cancer, cut my stomach out, but I want it to be reversible.
Right.
No one wants their cancer back.
Yeah.
And it's the same thing, but to sell reversibility was like a way to push a band. Now look at a sleeve. A sleeve cuts off most of your stomach and leaves you with a banana shaped sleeve, like the sleeve of my shirt, right? A hollow tube that's thin and narrow. That's what your stomach becomes. It's not a device that's like a long plastic sleeve. It's just your stomach, but it's shaped like a hollow tube that's like a banana. And by cutting off 3/4 of the stomach, your ghrelin, which is made by the stomach, it's a hormone made by the stomach to stimulate eating, goes to the floor. And therefore people say like, I surgically removed their appetite. They're not interested in food. They're not thinking about food. And because the mechanical function of the stomach is so much less, food is less broken down and in the intestines gets further down. So even though you haven't operated on the intestines, when you get a sleeve, your GLP1 levels go up because the food is less mechanically broken down. So it makes it much further in the intestines, stimulating those hormone release from the end of the intestines. A gastric bypass goes even further. It takes your stomach and staples off a small little pouch the size of an egg, and then takes your intestines and connects it at like the midway point of your intestine. So the food goes straight from that little pouch with minimal breakdown right into the like 50-yard line of your intestine, or even the 30-yard line of your intestine. And that's going to really stimulate the end of your intestines or the hind gut to release GLP-1. And that's how.
Oh no, we lost you. We had everything going so great. It's okay.
No.
We lost you, Doc.
Am I there?
We can
I
hear
can
you.
hear you.
That's fine.
You can hear me?
Hear you.
All right, we'll get
Yeah.
there.
Yeah.
There you go.
There he is.
Okay, I'm back. So
Ooh, I like it.
it was by trying to figure out how gastric bypass was so effective in doing what? Curing diabetes. That led to the revolution of GLP-1s. Because what they saw was people who got gastric bypass, they were able to come off their insulin completely before they even left the hospital.
Wow.
So it clearly wasn't weight loss. Something else was going on that
Yeah.
allowed diabetics to come off their medications.
I
And
had heard that.
And
Wow.
so by reverse engineering and doing studies of the hormone changes in the GI tract after gastric bypass compared to
Yeah.
before gastric bypass, that's where they came to this understanding of GLP-1s for diabetes. And that's why all the GLP-1 medications, Byetta, Victoza, they all come out as diabetes medication.
Yeah.
And I saw early on that these
Yeah.
medications had effectiveness with weight loss,
Yeah.
but it didn't really click as something to do with non-diabetics.
Yeah.
But clearly the data was there, and that was capitalized by Novo Nordisk when they rebranded Ozempic as Wegovy.
Yeah. Ooh, good
So
segue. That's
That's
fascinating. So,
great.
like in tech marketing, because
Wow.
y'all know I don't work in healthcare, but I'm a tech marketer, and we call things reverse engineering a lot when we're like taking things and breaking them down. Is it kind of like that?
yeah, that's
Wow.
how they got GLP-1 meds, by reverse engineering the hormonal changes in a gastric bypass.
Wow.
It makes me
Heard
think
that.
about that, like, was it really physical or is it mental? Like,
Yeah.
the compulsion to binge has definitely subsided for me.
Mhm.
But that's interesting because for years, doctors would, what is it? They give you ADHD drugs or anxiety medication,
Yeah.
but that's you're seeing things kind of blur, like lines are getting blurred with that,
Oh
you
yeah,
know?
and there we know there's overlap because we know
Yeah.
that ADHD medications that are stimulants cause some degree of weight loss.
Yeah.
That's working on a different brain mechanism in the hypothalamus than the
Hmm.
GLP-1 medications, but it stands to reason that people on GLP-1s, who experience less anxiety, maybe there's a role for those medications strictly for anxiety. And I have patients
Hmm.
who have come seeing me who need to lose 5 to 10 pounds, but have heard about the anti-anxiety effect of these medications and are asking me to put them on the meds.
Yeah.
And for the right
Yeah.
patients, I think it's a reasonable application.
Wow.
That's
Interesting.
And there's
fascinating.
studies about it. The impact with anxiety is about 5 times more than with depression.
Hmm.
It's really quite compelling with anxiety. As a medication for depression, the jury's out, and we obviously need a lot more studies before any of this can be, rolled
Yeah.
out as primary treatment. But if you're obese and anxious, it's like potentially killing two birds with one stone.
Yeah, for sure. I
Wow.
have to say, and like you
Wow.
said, there's still a lot to be, I think, learned and discovered with this.
20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Yeah, that's a common misconception. We were just talking about how with the title "Fat and Lazy,"
Ugh.
that the I know the misconception is that if we're gonna for those for those of us who are taking the GLP-1 medication, I am taking Mounjaro, is that it's cruise control. And that we know that's definitely not the case. You still definitely have to work at it, incorporating the fitness and diet. But for those of us in the obesity community or those who are looking to maybe make that journey or approach this with their medical provider, do you have any sort of tools or things that would be that our listeners could put in their toolkit when they're approaching, let's say, insurance or their providers?
For getting
Oh,
approved
for
for
getting
Mounjaro,
approved for Mounjaro, GLP-1s, anything like that.
well, obviously it's difficult because
Yeah.
as backwards as society is when it comes to looking at obese patients, it's influenced doctors, in terms of
Yeah.
how they treat obese patients, and it's influenced insurance companies in terms
Oh,
of
yeah.
getting approval for obesity services. Take surgery, for example. I would never have to spend more than 5 minutes to get someone approved for a surgery on their stomach, like anti-reflux surgery. If someone has bad heartburn, I can just basically write a note that says the patient has clinical symptoms of heartburn. Maybe I do an endoscopy and get some biopsies and submit that, and they would be approved. But if I wanted to do a sleeve on their stomach because their BMI is 45, they're 120 pounds overweight, all of a sudden the patient needs to undergo 6 months of medically supervised visits before their surgery will be approved. They need a site clearance before their surgery is approved.
Wow.
Because
Wow.
insurance companies treat obese patients different than they treat non-obese patients. They don't treat obesity in the same way as a biological disease. For them, they need to show that 6 months to prove some sort of level of commitment, as if the obese patient who's gained 120 pounds has proved that they are not committed.
Right.
Whereas if they're coming for a surgery, they've probably done 50 diets that have failed.
Yeah.
Indeed.
Yeah. Indeed.
And it's just epidemic.
Yeah.
In insurance companies and doctors. I had someone write me on TikTok who was a nurse who says when she goes to her doctor, she can engage in things on like a medical level where the doctor seems to respect her and acknowledge her level of expertise by being a nurse and being in the healthcare community. But when she approached him about GLP-1 medications, all of a sudden the doctor suggested that she keep a 6-week food journal and count calories.
Yeah.
And
that gets a little bit patronizing to me, like, because I've been through that, right? And so that's how I feel. But keep going.
So with regard to getting insurance authorization, it's difficult because some insurance companies have a complete, we don't cover weight loss services.
Right.
Other ones, will only approve medications if you're diabetic. Some will approve it if you're pre-diabetic, and some will approve weight loss medications like Wegovy. And it's a crapshoot. So you really have to understand what insurance you have specifically. You have to look for exclusions to the benefits that are like in the fine print. But a doctor who's motivated to get you the medication is the first step, because without that, you'll never get a pre-authorization. So you have to go to like an obesity literate doctor. That's the first step towards getting authorization for medications.
So that's the first step, everybody. It makes perfect sense.
If you're dealing with a doctor who's dismissive, that's a major red flag. That's not someone who's going to go to the mat to try and get you these medications, because they probably don't even believe you need them.
Right.
Yeah, I actually feel that now. I feel those endorphins.
A walk will
make you feel a little, Kat.
I get it.
Did she say kill her husband?
But I said walk, not kill your husband.
No.
Like, I'm staying out of that conversation, Dr. Rosen.
You didn't have the tools, Kim.
Yeah.
You didn't have the tools to feel it. And these medications for some people function as that tool. It unlocks that capability, because that was hidden by so much noise and so much hunger.
Yes.
And that's individual, and that's part of the disease.
Yeah.
And that's genetic, biologic, physical. It's all those things, but it's not laziness, and it's not a weakness of will, and it's not a failure of self-control.
Yeah.
It's not any of that. If you take an obese person and you take a normal weight person and you put them in front of salads and pizza, the distribution of people who will go for the salad first and versus the pizza is probably going to be the same across both populations. If you give an unlimited buffet to an obese person and a normal weight person, the amount of calories consumed by each will probably even out to be the same. Now, the obese person might retain more of those calories. The obese person might have a quicker rebound in their hunger drive after a certain amount of calories, but that's all, you know, hormonal and genetic. The obese person might run at a lower metabolism and therefore retain weight eating the same number of calories as a normal weight person. But none of that has any, you know, there's no control. There's no conscious control over those mechanisms. So in order to counteract them, the recommendation is some sort of superhuman level of restraint.
Yeah. That's so true.
Or Dexatrim. I'm just kidding. That's just
Trim.
awful.
Cat,
Awful. Like,
old
just, I'm having PTSD today. You know?
Ma Wang. Did you hear about Bethany Frankel and
Oh,
Ma Wang?
no, you called her Dr. Bethany Frankel.
I mean, she's parading as one.
Clearly.
That was an epic
She's
one.
cosplaying
We were all
as
sort of
one.
trying to debunk that whole like no Ozempic BS. If y'all ain't seen it, Google, because it's there. Because if it ain't there anymore, somebody's doing it or done something with it. The internet is evil and amazing all at the same time, you know. But she was saying like a lot about that, right? And she said, just, I mean, like talking about people's personality being changed, and it must be the Ozempic and all this different stuff. I was just like, good Lord, what a ding dong. Like, if you have a platform like that, don't go run your mouth like that unless you say, like, hey, like, this is my opinion and I'm not really sure. And even then, if you have a plus size brand clothing, don't talk bad about the people that buy your shit. Like, you know, right, Kat?
She sells plus size. I bought one of her sweatsuits like a couple years ago.
No way.
Yeah. And it was hella flattering, but we're getting off topic. It was a really nice sweatsuit.
Are we?
This is Dr. Frankel. She sells sweatsuits.
Dr. Frankel.
Skinny girl? Dr. Skinny Girl?
It was skinny girl sweatsuit.
Wow.
Isn't that like such an oxymoron? Your brand is Skinny Girl, but you make plus size clothing.
Odd.
Like, I don't know if it was plus size. It was just like, it was available in plus. It was size inclusive. That's
Oh. As a marketing person, I find that very.
Oh, okay. Gotcha. Okay. Yeah, and with her, I don't even want to say her name, with her saying all of that, and with, you know, a person like me who's a member of both communities, you know, sometimes it's difficult because, you know, you have the obesity community, you have the diabetic community, but these GLP-1 drugs are working so well for both communities, which it's really almost one. Why do you think that the GLP-1s are working so well? Well, and I think you kind of answered it, but for diabetics, as opposed to just insulin or metformin, and why do you think it's working so well for those that are obese?
I think it works great for diabetes because it primes insulin release. Okay, that's what it does. And for a diabetic, a type 2 diabetic, you're often resistant to insulin, meaning it takes extra high levels of insulin to stimulate all of those mechanisms that you need to process calories. And the calories go from your food, from your gut into your blood. And if you're consuming sugar or carbohydrates, that's going to raise the sugar in your blood. That's why you do finger sticks and check your blood sugar. And if you're resistant to insulin, then it takes a lot of extra insulin to get that sugar out of your blood and into your cells where it belongs and can sort of power the metabolic activity of those cells. So anything that increases insulin is good. And especially if it can be increased endogenously, meaning within your body, instead of exogenously outside your body, like insulin injection. So the fact that this hormone can prime your GI tract to promote internal insulin release helps you control your blood sugar tremendously. And they're finding that, you know, insulin is also a very profound fullness hormone. Think about why it works, right? Your body gets in a lot of food. We got to metabolize all this stuff. We got carbohydrates in here. We got fats, and the bile and the pancreas work to sort of send out enzymes that break that stuff down. And then it's getting further down into the GI tract, smaller and smaller bits, constituent parts. And then it starts getting extracted by that intestine into your bloodstream. Now we got fats and we got glucose and carbohydrates circulating the blood, and it's got to get from your blood into the cells. And while all this is happening, you don't want a lot more food coming in until you've gotten those nutrients out of the blood and into the cells. So the insulin that makes you metabolize that food and draw those carbohydrates and sugars into the cell also tells your brain to make you feel less hungry, so that you're not putting more into the system until the blood sugar goes down, because it's all in the cell. And when your blood sugar goes down, that triggers hunger. So low blood sugar triggers hunger. So it's like this scale that kind of is constantly in movement. And so because GLP-1 stimulates insulin release, and because a non-diabetic person is not insulin resistant, they are sensitive to insulin, more sensitive than a diabetic. The weight loss in a non-diabetic is more profound with these GLP-1s than in a diabetic.
Wow. And I'm so glad that you answered that, because I knew it takes diabetics longer to lose weight than it does for non-diabetics. So, when you see all of these, I lost 6 pounds this week. I'm like,
crazy.
I
never lose that much.
Look, I gained 1.8, and that's a true story. I actually weighed myself yesterday and I gained 1.8 pounds. But I'm like, oh, but now that makes sense.
Right. If you look at the weight loss data from the medication that it came out, it's surprisingly low compared to what we see with non-diabetic patients, because all that data was generated with diabetic patients.
Right. Interesting. Yes. And that's what I was telling someone, was that you have to remember that the trials were with diabetic patients. Mm-hmm. So that's the information that you're going to get. And again, I'm not saying diabetics are all that. It's just that is what the trials were for.
These medications have really put a rift in the communities.
Yes,
they have.
Look, it is an off-label application, and that needs to be acknowledged, that it's an off-label use of a medication that's been FDA approved for diabetics. That doesn't mean that it's like only for diabetics. That just means that the FDA has approved its use for diabetics. Now, what if you're just a little diabetic but really, really obese? Who gets who gets that Mounjaro? If it's just there's one pen and two people, are we going to do comparative suffering of diseases? Like, my disease is worse than your disease?
Yeah.
Thank you.
And I think it's
Thank you.
I think the whole point is that people don't look at obesity as a disease, at least like the Gen Pop, like they don't look at it that way. They don't and I mean, I've even explained
even
to
the
you,
diabetics,
like, no one ever said that to me. No one ever said, you suffer from obesity. Did you know that it's a chronic disease? Like, no.
Right.
Yeah.
I just thought I was pathetic. Like, I really just did.
Yeah.
It's going to be a slow climb to educate the population.
Yeah.
But we got to keep fighting that fight.
Yeah, we got to.
I see the climb starting.
I see it starting. And
we're at the base of the mountain. We're maybe a little bit up.
We're like, maybe the base is here and we're maybe like right here.
We're on the hiking trail, right?
Yeah.
All the people that can't.
At least we're not on the base.
Where are we? Because we keep going. We're over here, and then we're here, and then we're here. We need a visual.
We're on the mountain.
We're on the mountain.
You know what? We are on the mountain. And I just wanted to ask, in terms of the WHO, the World Health Organization, I know that was really big news about them recommending GLP-1s for, as an essential medication. What are your thoughts about that, and how do you think that that decision or that recommendation will shift the narrative for obesity?
I think it's really profound. I think most people don't appreciate how profound it is, because if you look at the medications on that WHO list of essential medications, most of it is for deficiencies. Like iodine is an essential medication to prevent thyroid goiter,
Wow.
So vitamin C is an essential medication to prevent scurvy. It's all about like how, and
It's old
it's
stuff,
really
right?
focused on a very colonialistic Western medicine view of third world countries, frankly. So it's like the first medication that's like pointing at the first world countries and the first world problems, because the fact is that many more patients in the world, many more people in the world suffer from this overabundance than, diseases related to overabundance than diseases related from a lack of resources.
Yeah.
And so this is the first medication that's been recommended that focuses in on that recognizes obesity as a worldwide problem, and diabetes as a worldwide problem. And it speaks to how effective these medications are.
Yeah.
They didn't recommend metformin as a, as an essential medication.
Yeah.
They recommended liraglutide, which is, Victoza and Saxenda.
Dr. Rosen, my last question, fellow Virgo, is how, with the weight loss success from GLP-1s, do you believe, and there's now a school of thought of saying that there may need to be a layered approach to weight loss, because these GLP-1s can only take you so far? And if you have a certain weight loss goal, that you may need something else in addition to the GLP-1s. What are your thoughts on that?
I think a holistic approach is great. I think with every patient who's on a GLP-1, if you want to get as far as you can on that medication, a commitment to putting the right things into your body from a food perspective is really important. Exercising as much as you can. I mean, it's old, but it's tried and true. And when delivered in a holistic approach with something else that will drive the needle, then it's very effective to help it be more successful. It does not work standalone to get rid of obesity. It might work to prevent obesity, but I do think there's a role. And I think that engaging with a healthcare professional like a nutritionist in that setting, and it has to be the right nutritionist. It cannot be the nutritionist who says you don't need those meds. I have the answers. That's not who you want. You want the nutritionist who understands how these meds work, who can talk to you about, like, okay, on the first 2 days of your injection, like, you're not thinking about food at all. What can we get into your body that will drive your energy, and make sure that you put healthy things into your body when you're not hungry, and can sort of guide you along that route. I think that can help you get more weight loss on a per week or a per month basis while you're taking that medication. Same goes with exercise. I think that, people are saying, is this going to replace bariatric surgery? I have patients who, I did a sleeve on one person, and she said, my sister started tirzepatide the same week I had my sleeve. 6 months later, we're at the same weight.
Wow.
Yeah, like that's unheard of. That's unheard of. And does that mean it's going to replace bariatric surgery? And I don't think it is. I think that there's going to be patients who don't want to be on this medication, or who have side effects from being on this medication, but are going to want the effect of that medication, and they will be good candidates for surgery. I think there are going to be people who would prefer to have a surgical intervention than put a certain medication into their body for the rest of their life. I think
Yeah.
there are going to be people who can't get all the way that they need to get, who need more mechanical restrictions
Yeah.
on top of this medication. So there's a role for combo therapy in terms of surgery and medication. It's incredible for my patients who have lost a lot of weight and then regained weight to sort of take them back the way to where they were. It's very effective from that perspective. I think we're just learning on how to use these medications, how to approach maintenance when someone gets to their goal weight, and to not be a doctor who like takes it away and then the patient's left to fail.
Yeah.
Because the majority of patients will gain back the majority of their weight when they're taking off these medications. Unfortunately, the body doesn't reset at a lower weight. You talked about how you gained weight during the difficult times in your life and being on those medications. Well, that allowed your body to set at a new equilibrium. And that's where your body always wants to get back to. But when you lose weight, it doesn't set at that lower, healthier weight, unfortunately, because that's not how evolution programmed us.
Wow.
That's fascinating. Yeah. I think that's so interesting. I think this kind of goes back to something that's kind of controversial right now, which is the fact that, for example, Wegovy, right, was approved to be able to treat children that are 12 years and up who struggle with obesity. Now, whatever those definitions are, I don't know, but it's something that's gone around a lot and people have some pretty strong opinions there. Because I know a lot of doctors have told us anyway, that treating obesity as soon as possible is going to have the best outcome health wise. And so I think this is, I mean, I look back and I think I'm glad that wasn't in existence then, because I think it would have been hard as a kid for me to go, I think I probably would have wanted to do it, but I don't necessarily think that was best for me. But I think everybody has differing opinions. And I think understanding the science of it would be interesting.
Yeah. I think that it's a controversial topic.
Yes.
Especially in today's day and age, because on a totally unrelated topic, there's so much heat in the news about trans kids and hormones for trans kids and surgical procedures for trans kids. And there's like an inevitable co-optation by people who don't want obese kids on these meds for some reason, where they're equating them. And it's really not apples to apples at all. It's completely unrelated, frankly.
Yeah.
But it bleeds in. So you have people who say like, keep meds away from our kids. And when the ruling by the NIH about the use of semaglutide for kids 12 and older came out, you saw immediately that sort of, and mostly it was in conservative media. And it's no coincidence that it was conservative media, because it piggybacked that whole trans thing where they were saying like, keep these meds away from our kids.
Yeah.
So I come from it from a medical perspective, and I don't treat kids. I don't operate on kids, but there are bariatric surgeons who do operate on kids, pediatric bariatric surgeons.
Wow. Didn't even know that.
Yes. And there's a lot of totally appropriate indications for pediatric bariatric surgery. There's some diseases like Prader-Willi, which are genetic diseases that come with a hyperphagia, which is hyper eating. Phagia is eating, and it's a centrally controlled hyperphagia. And these kids hit 300, 400 pounds before they're adults.
Wow.
Like you can be 10 years old. Like the treatment for parents with Prader-Willi is to put a padlock on the refrigerator.
Oh my goodness.
And that's an excellent application for a sleeve gastrectomy for patients. And there's been growing pediatric bariatric surgery for a while, for the last 10 years. Wow. And now this brings into question, maybe we don't need to do a life-threatening surgery on a kid if they have access to these medications.
Indeed.
And there can be health ramifications to being 100 pounds overweight when you're a teenager.
Yeah.
but I don't see that as nearly as evocative as the social ramifications.
Yeah.
And the ability to take someone who is not just socially an outcast, but is so physically limited in their interaction with their peers, and giving them the opportunity of having a high school existence where they're not so marginalized.
Yeah, exactly.
And a
a really
college
good
experience,
Yeah.
and how that can impact their emotional well-being for life.
Yeah.
That shouldn't be discounted.
Yeah.
And to not need to do it through surgery, to have these medications available for a 12-year-old where it's been proven to be safe
Yeah.
for that age group, it seems like it would be irresponsible to not consider it
Yeah.
for a kid, to not appreciate those benefits, risks versus rewards.
Well,
And
a
if
lot
the
of that
risk
is
low,
ignorance, you know,
I
like what
agree.
you just mentioned. I mean, I didn't even know that. And I suffered with, childhood obesity, and I didn't even know that there was, so I think there's like nobody talks about that. They hear this stuff in the news, and the news spins it as much as they can to fit their own agenda, to further whatever they're wanting to do, and nobody says, but did you know that there are these kids that suffer with this and this can help them in this way? And maybe we don't have to, like everything you just said, like nobody says that. Nobody
The
says that. They're just
social,
like, oh, it's moms that are upset because,
true.
their kids are 30 or 40 pounds overweight. Like that's what people hear, and it's not actually the case. But I think it's good, like for you to say, let's just talk about it. Having a conversation with your doctor, whether it's about your child or yourself, should not be so taboo that you can't just say, what are options? I think that's important for people listening, for yourself, for your children. It's something to consider. It's a conversation having research and education to explore,
and patients need to be empowered. If their
Yes.
doctors shut them down on this,
Yes.
they need to not just find a new doctor, but let that doctor know why they're finding a new doctor. So that
Yes.
doctor is spurred to get educated and to open their mind about how they view obesity, both as an adult disease and a childhood disease.
Yeah, absolutely. Fascinating.
Food has definitely been a very dominant voice in my head. That's not the main focus anymore. Dieting, exercising, and adding GLP-1s through Roe is a game changer. I have such a sense of mental freedom since I started with Roe. Food no longer controls my thoughts. Family time used to revolve around food, and now it revolves around what we're gonna go do together.